Welcome to the What About Rural Health podcast, a place where research, policy, and real life stories come together to ask the critical question: what about the communities too often left behind? I am Chinasa, a development and global health policy strategist. And for me, this work is personal. From the village health workers struggling with limited supplies to the mothers walking miles for care, their stories shape the policies we need. Join me as we uncover challenges, spotlight innovations, and amplify the voices of those at the heart of rural health systems. Because every community matters, and it is time the world listens. Hello and welcome. You are listening to the podcast that asks the question too many people forget: what about rural health? I am your host, Chinasa, and together we are uncovering the stories, challenges, and innovations shaping healthcare in overlooked communities. Today we are taking a different kind of journey, one that looks beyond clinics and health facility management into the social systems that shape health, especially in rural and underserved communities. We call today's episode Community First: How Policy, Psychology, and People Power Transform Human Rural Health. It is exactly what it is: a deep conversation into the human side of health system. And the truth is, health doesn't begin in the hospital. It begins at home, in our communities, and in the policies that shape how people live and are cared for. We will be talking about community-centered systems, gender and protection, and their intersectionality with healthcare, the way people live and identify intersection with access, dignity, and care. My guests bring rich experience to this conversation, having worked at the intersection of public policy, development sector, psychology, and community resilience. And I am so looking forward to the direction this conversation will take us to. But before we begin, let me introduce you to her. She is someone I deeply admire, not just for the work she does, but because we walk similar paths. We both earned our master's degree at the University of Chicago Harris School of Public Policy. And it's been a joy watching her continue to lead on in her space. Dr. Titilayo Ogumbambi is a community psychologist, public policy expert, and social impact leader. She has over 13 years of experience in international development, refugee support, gender protection, and social policy reform. Her journey began in rural Nigeria and with survivors of trafficking, advancing gender equity, or shaping social protection system for vulnerable population. She uses community approach to do all of these things, and currently she's leading anti-trafficking services at Heartland Human Care Services. And she's also the founder of Boundless Hands Africa Initiative. She also co-founded an initiative called Emerge. Both of these organizations advance survivor-centered support for women and girls in underserved communities in both Nigeria and in the United States of America. Her work has been recognized globally with honors including the UN Women Chicago Champions Award, the Mandela Washington Fellowship, and she's been selected into the Obama Foundation's Change Collective. She's also an author. She authored a book called Emerge: Rising from the Shadows of Sexual and Gender-Based Violence, a powerful call to action rooted in the voice of survivors. Dr. Titi brings an essential lens to our conversation on rural health, reminding us that care must not just center on medicine, but on communities themselves, on equity and human dignity. Dr. Titi, it's truly a pleasure to have you.
Thank you so much. I'm really happy to be here today.
Thank you for joining us. As I was reading your profile, I'm like, wow, Titi, How do you do all of these things? Because every time I look at your work, your leadership, your advocacy spirit, I'm like, how does she do all of these things? Like, how many heads do you have? So tell me, what keeps you going? What's fueling all of this passion and commitment all through these years and across many spaces? I know there are things about your resume that I missed out, your engagement with the UN system, your work with Lagos state government around GBV. So there's a whole lot to say about you. So before we go on, and I know you have a lot to answer, let's take a quick break. If you are joining this conversation, don't forget to subscribe to What About Rural Health on all podcast streaming platforms. We are on Spotify, Amazon Music, Apple Podcasts, and listen now. We are also on YouTube, so you have different options to follow us. Your support means a lot to us. Like, leave a comment, share, but most importantly, leave us a review, because that helps us to discover important conversation that keeps rural health conversation going. All right, back to the episode. You are listening to What About Rural Health with Chinasa Imo, and with me here in the studio is Titilayo Ogumbambi. Titi, I yield the mic to you.
Thank you so much. Just like as you were reading my bio, a lot of times I'm like, am I the person you're reading?
I know that feeling.
The feeling. So basically, the topic we're discussing today, when you sent me that email, I was like, this is me. Just because I'm a rural girl. I started my advocacy, my community engagement, community building from rural Nigeria, Jos Plateau State. I remember when we met years ago that I'm like, I'm from Jos. You were like, oh, yes, I did my NYC in Jos.
Yes.
When a rural girl sees a gap and decides to start asking questions about the issues in her community, that is what keeps me going. I grew up home full of boys. I had just one sister. And right from when I was a child, I began to ask questions like, why are the boys allowed to do these things and why am I not? Mm-hmm. And then I'm sure you've heard several of my stories where I was protecting my fellow girls in school and fighting the boys when they bullied the girls. So that is exactly where I came from. And what keeps me going? I talk about my work in grassroots communities in Nigeria. I'm that kind of person that just goes in and creates solutions by answering those questions and wait to be recognized. So when I started, it was just about, these women need to learn what their rights are. These women need to know where the services that are available for them are. These women need to understand their culture, not to leave those cultures, but to understand the positive aspects of their cultures that they can take to become who they really want to be. And, from doing that, I began to be recognized. People were asking, who is the person doing this work? And then the UN Women Nigeria wanted to, partner with me. The American Embassy in Nigeria wanted to partner with me just to increase the reach of the work I was doing. And, carrying that beyond the Nigerian border into Africa as a whole. And here in the United States, I'm also here asking in this community, why is this happening? How can I solve the issue? And that's what keeps me going. That one person that I save from any form of gender-based violence, preventing issues in my community, is what keeps me going.
You can take a girl to different communities, but you cannot take the advocacy from her. From Nigeria, she moves to the US, and the same question, she keeps asking it in every community that she goes to. That's really interesting. I must commend you for all the work that you continue to do. So now let's talk about what often gets overlooked in rural health conversation. The social and psychological barriers, especially for people who are displaced, marginalized, or just trying to survive in under-resourced setting. So from your work and your research, what are some of these biggest barriers that you have seen, and what does it take to start breaking them down?
Sure. Thank you so much for that very important question. So when we talk about rural, it is very important to understand rural is not one size fits all concept. The term means different things, depending on the country and the system that serves this community. And they all differ, widely. So in the United States, rural communities are typically defined by population density, urban, centers. And these areas are often categorized by shortages in healthcare, limited public transportation, hospital closures, and all that. While in other developing world like Nepal, Nigeria, where we're from, over 80% of this population live in rural areas when we call remote mountains that transportation or telecommunication cannot get to. So healthcare delivery has often depended on community health workers and outreach clinics and travel and all that. And also like in Nigeria, 75% of the population live in these remote areas. So what are the limitations? Lack of skilled community healthcare workers, lack of transportation. We have communities that don't even have roads within them. What happens when a woman gets into labor at night and she has to, get into that? Finance. Where is the money to get the adequate medicines and resources that people need in those rural communities? So transforming healthcare, we must expand the coverage, redesign systems, and reflect, the experiences of people. Another factor is cultural beliefs and differences. So depends on your culture, putting in gender-based violence, which is my focus. Before people can reach out and say, they want to go to a shelter to ask for help, or they want to speak about their experiences, culture also limits them from even speaking up in the first place. So those are, the kind of factors that I see that, really affect rural health.
Thank you so much. And I am going to follow up with another question, just a rider to your response. So when we look broadly, beyond Nigeria and US and center the global space, what are the social factors? Now I'm very, very specific about the social factor that we tend to overlook in rural health program. What's missing from the way we talk about rural health within that global space?
Yeah, I really like that perspective because every time people talk about barriers to healthcare, they think it's just access to clinics, which is far from it. There are invisible walls of things like fear, stigma. I call them psychosocial barriers. Things like fear, stigma, mistrust that people stop from even seeking help, social isolation, culture, language barrier, which is a very, very big issue. A lot of experts in health, they have language barriers if they're, allocated to the communities and they can interact with them. So these are things that make people feel less safe and misunderstood. And talk about the empowerment bit of it. People will not access things if they are not educated on the perspective that things that they need. So those are just few.
Thank you so much for that response. You and I know that health is not just about the body, particularly for female gender. And I'm using the word female gender to be very clear about assignments of, gender at birth. We have male, we have female. So for the female gender, it's deeply tied to power, protection, and their lived experience. How do gender-based violence, mental health, and structural inequality show up in the rural spaces, and how do they shape who gets care, how care looks like or don't even look like for women and vulnerable groups?
This is a very multi-layered question. But I like how
you are a doctor. I should throw you the punch and, trust that you came very prepared.
Yes, I'm always very prepared.
I know. Thank you so much.
So I would like to, break the questions down a little and go back to when I say you can't talk about rural health outcomes in isolation. They are deeply shaped by layers of social context, especially when gender-based violence, mental health, and inequality are in the mix. So for gender-based violence in many rural areas, The major issue is underreporting due to stigma, lack of services, patriarchal norms, and survivors may be isolated or blamed or even economically dependent on their, abusers, which keeps them trapped and unwell. Then when you talk about mental health, the trauma of gender-based violence often leads to long-term psychosocial effects, depression, anxiety, PTSD, which a lot of rural communities don't even believe in things like PTSD. They will tell you that
It's spiritual.
Exactly. But mental health care is either unavailable or a taboo within these communities. Then we talk about the structural inequalities. Now, layers of lack of transportation, poor education, language barriers that I mentioned before, they widen the gap when people are trying to actually get help. So when a woman in a rural community experiences violence, she's not dealing with the health crisis alone, like we say, clinic or go to the clinic. That's not the solution. She's navigating trauma, lack of safe space, no mental health support, possibly no income, and a system that even can't support her. And all this leads to poorer health outcomes. Not just for her, but often for her children. We're talking about community. Community is not about the sole man or the woman. It's about the children. It's about the neighbor. It's about the environment.
Everybody get a share of it.
Exactly. And I've worked with displaced women who fled from violence, but once they even relocate to another place, they find themselves even more isolated. And again, without support, sometimes no access to their children, which is the mental perspective we're talking about. And mental and physical health deteriorates every individual. And it doesn't deteriorate them alone. It affects the community that they operate in. It affects their work because they can't even go to work. So addressing rural health means we must integrate gender-based violence prevention, mental health support, economic empowerment, which is the main thing. When women are economically empowered, they turn around communities.
Thank you for your response. And this just get me thinking. And I think that at some social conversation that we've had this conversation where I shared with you, and for our listener, many of you don't know that I own a nonprofit in Nigeria that also do gender-based preventive, but we come from building leadership capacities of women. Now, our program wasn't targeting gender-based response. It was, let's build the capacity of women to become leaders within the community and use their voice to work with stakeholders to improve outcomes for vulnerable population and those who are facing gender issues, right? That was the goal. And then issues started coming out. The women that we've even selected and thought they were leaders were facing GBV themselves. And the basic issue was economic empowerment. They have problems with even going to the police to report or going to the health to seek. So if you don't put all of these things together, not just addressing one, but the three of them together, you've not even started at all. So I'm glad that you provided this response. And I know it's a lot to digest for our audience. So let's take a quick break for them to assimilate all of these things, and then we'll come back. Do you have a rural story that needs to be heard? Whether you are a health worker, a patient, a policymaker, or an advocate, we want to hear from you. Share your story on our website. Go to www.whataboutruralhealth.com/stories and help us spotlight the realities behind the data. When you submit your story, someone from our team will contact you with details on how to get you published on our newsletter, on our websites, or other media platform based on the kind of story that you submit. And you can submit, written articles, video, or audio recordings. They are all accepted in our platform. Welcome back. You are still listening to What About Rural Health with Chinasa, and with me in the studio is Dr. Titilayo. So, Titi, I know a lot of your work has focused on intimate partner violence prevention, especially in rural communities. How does that connect to rural health in your view? And what are some of the biggest gaps we need to be paying attention to in those spaces?
Thank you so much for that question. So, like you know, intimate partner violence is a public health issue, like I always remind people. And preventing it is different from when we're trying to prevent like a pandemic or we are trying to prevent, like a health issue that just came up. Intimate partner violence have been in existence even before me and you were
From
born.
time immemorial.
And with the data we have, it says 1 in every 3 women or 1 in every 4 men will go through intimate partner violence in their lifetime. So when we talk about prevention, we always critically look at what is it that is currently going on in each community. Every community is different. So like you said, when I was doing intimate partner violence work in Nigeria, the determinant, like you say, the social determinant for that problem was totally different. Not totally, but in a way different from when I came to the United States. So in Nigeria, it was heavily because we're a patriarchal society. Women were brought up to think, they're kind of commodity, if I may say. Like during my research, I found out that bride price is still being paid in a lot of communities. And when somebody pays something on your head, it means you are that person's property.
Mm-hmm.
So moving from that kind of cultural deepness, we need to first of all find out what is going to work for that community. And one of the things I was proposing is that instead of doing bride price, how can we do a gift exchange during marriages so that it brings away that power imbalance between couples? But you can't just go to a community and say whatever you've believed for 200 years ago is wrong. You have to go and explain the reasons why you are, and you must go with a different intervention. So in case you're a community health worker out there, I'm just saying, if you're really into rural health, I'm just saying for you to be able to provide solution for whatever gaps you're trying to address, you must bring an alternative. And the alternative would be that you are telling people that what you are doing, I'm not saying is wrong. I'm just saying there's a better alternative. And then coming to the United States, for instance, intimate partner violence, there are already structures, there are services. Compared to Nigeria, where yes, we have shelters, but how many? And in what communities do they even have the shelters? So if you are somewhere like in Lagos, which is an urban area, which is not part of our conversation, you might be able to get. But if you're in a rural area,
like my village.
Exactly. They don't even know what a shelter means.
In case you don't know, my village name is Nkoro. It's somewhere in Nkoro, Abia State. Now imagine there.
Exactly. So when you come to prevention in somewhere like the US and the communities we work, yes, those services are there. Sometimes they are overwhelmed or they are not available. So my message when it comes to intimate partner violence and policies is that for you to be able to create a solution in a particular area, you have to understand what the problems are. And every community is unique. So when you understand what the problem of the communities are, you don't go into the communities telling them that whatever they have been doing is wrong. No, you're going in to say, oh, I understand this is what you guys do, this is what you understand. But have you thought about trying to do it in a different way or in a certain way? I'll also go deep into a community psychology perspective that I learned, ABCD, asset-based community. So we'll definitely dive into that in the questions to come, because I'm saying you should go in with a different perspective, but some people might not know what I'm talking about. So I'll dive into that.
It's good that you mentioned asset-based community development. And I know that we've had 2 speakers, 2 guests here who emphasize the importance.
That's the only way rural communities can address health.
The fact that you're mentioning it means that we need to take cognizance of that model when we are moving into community. And I like the fact that when you were talking, you keep mentioning policy. So let's talk policy. You are a policy, you're a policy student. You continue to be a policy student because for you to do the kind of work you do, you need to understand systems. And both of us, we know how policy can either open doors to healthcare and social welfare, or completely shut people out. So, from your perspective, how do policies enable or block access to care in marginalized or rural area? And in your world, in your own world, say we create an alternate cities world, what would a better policy look like?
Yeah, thank you so much. And I just want to remind the audience that my focus is gender-based violence as we keep talking about
Yes.
policy.
Yes.
Yes. So policies really shape every step of survivor's journey. As a gender-based violence strategist or gender person, activist, and all that, survivors are people that have either experienced any form of gender-based violence in our lifetime, and those are the people we work with. So when you talk about policies, can they report the abuse? It's policies that shape all those things. To whether they can access housing, it's policies. To whether therapy is available. And then even their overall safety in communities, it's policies that shape all those things. So when we talk about bad policies, it often creates like administrative burdens, excluded, undocumented people, especially in, big communities like here, displaced people, or even uninsured population. So policies and whenever you say a community is safe, what are the policies that are safeguarding? We talk about safeguarding. What are the policies that are safeguarding these communities? Good policy is trauma-informed when it comes to gender-based violence and equity-centered. It closes the gap between the needs and the assets for, local services, reducing red tape, or even recognizing intersectionalities and vulnerabilities. So how are policymakers ensuring that all the policies that are being drawn, sometimes even policies that exist, have all these things in them, but are they being implemented? So
some people will be like, we have all the beautiful policies, but implementation is the problem.
Exactly. And looking at a rural community in Nigeria, I always like to go to Nigeria because that's where my work is based on. Are there policies that give rural communities insurance? Do they have access to the care that they need? Can they even be attended when they go? We see that in movies. The good thing about the United States, whether rural or urban, is that when you get to the ER, you will be
at least you get care.
Exactly. You will be attended to. That is the policy that is working. That's true. I will stop there for now.
Thank you so much. And I'm going to pivot a little bit to your work here. And you've done great work with displaced and refugee communities, many of whom are resettled in rural regions. What role does place, whether urban or rural, play in people's recovery and access to services? And how do the system, need to adapt itself to the realities that are on ground?
Yeah. So when you talk about the refugee space we have worked in, and almost everywhere I've worked in, I think this is the place that I became more passionate about. Because me and you are immigrants. We left because we wanted to leave. We left because we wanted to maybe come for education. Some people come for economic reasons. But refugees leave their community because they've been displaced. Some of them, before getting to this community that they are, they've gone through different kind of trauma. They've lived in camps. Some of them have lived in bushes and on the road.
Some travel by long waters in unsafe boats.
Exactly. So for every refugee I met, with my work at Heartland Home and Care Services before the policy change with the new administration, I was able to resettle over 500 new refugees in Illinois because I was heading and leading that program. But when you talk about their resettlement, rural resettlement, urban resettlement, it depends on the opportunities it offers. Affordable housing, employment, health system, cultural, linguistic, trauma-related services. Some rural areas are able to offer those opportunities, even in informal ways. And the refugees feel more comfortable in that setting. While some urban settings, they have affordable housing, employment opportunities like here in the US. But one of the major things they deal with is the language barrier. Most refugees that come from war-torn areas cannot speak English. So when they come, they first need to learn the language before they can even get employment. And then one other thing that we fail to recognize in this community today is refugees bring resilience and strength to wherever they go to. So are we, both rural and urban, are we tapping into the resilience and the resources these refugees are bringing in? That's another perspective I would like us to cover. But rural area often offers healing, safety, and also intentionally open their arms to receive the refugees. But urban areas, everybody is in a very fast pace. So apart from the policies and the structures that provide, facilities for these refugees, you might be able to say that. So it depends whether rural or urban. It depends if the resources are available for refugees. And one thing I want to leave everybody with is what I said at the earlier. Refugees come with a lot of resilience, a lot of experience. And when they get into community, what we can do is to open community up for them, support them with resources so that they can, first of all, live beyond whatever they've gone through and help build communities, which they are always ready to.
Thank you so much. This is really insightful and learning for someone like me who doesn't, that's not my area. So it's really an eye-opening for me to learn all of these things. One thing that I really appreciate about the lens that you are bringing to this conversation is the psychological side of health and not just the physical. Like, I haven't seen you mention, you've said things around access to services, and I kind of like put that in my head, including health facilities, but you haven't quite mentioned that, which means like we really need to pay attention to the psychological side of health. Why do you think trauma-informed care is so important in public health, especially in rural settings? And how can we make this to be more than just a buzzword that we throw around when we want to, make something sound very fanciful?
Yeah, thank you so much. I like how fancy it sounds. But again, trauma-informed care is a watchword that every industry, every perspective of health is supposed to be using. Mm-hmm. So it talks about the dignity, the trust, and the healing. I mentioned at the beginning, before you can provide a solution, you need to understand the problem. And that's where trauma-informed care, it allows whoever you're trying to provide care to tell you how they feel, what they feel, right? And as they're spitting it out, then you are identifying where the problem is coming from. So that's me just breaking down trauma-informed care for people that, don't really know. And trauma shows up in how people respond to care. So whether they avoid clinics or they mistrust or they don't trust who is providing service for them or feel unsafe, even within institutional settings. So how can institution begin to make sure that whatever facility or resources they are giving has trauma-informed care at the end of it to build trust? Because if people do not trust you, they will not come to you for help. So trauma-informed care recognizes that systems need to interact with people through choice, through collaboration and empowerment at the end of it. Why are you trying to find out the problem of somebody? You need to find it out so that you can empower the person. Wellness is a two-way thing. It's not about giving people medication. The person that is also taking the medication needs to be receiving the medication and following up. Because as a doctor, you can write a prescription for somebody and the person goes home. Do you know if the person takes or not? That is where trauma-informed care. Training frontline health workers to understand trauma sensitivity. So if frontline workers understand that it's a two-way thing between you, the service provider, and the patient, then they understand how the wellness of that person is a lasting process. And that is what the dimension of trauma-informed care comes.
Wow. Thank you for breaking all of this down for me. Like I said, I am learning, and thank God that I'm sitting down here. By the way, we are talking with Dr. Titilayo Ogumbambi. Titilayo, we often hear about community engagement, but it doesn't always go beyond town hall meetings or feedback forms. Like when you ask people, how do you want to engage with the community? Oh, we'll give them feedback form to learn how they feel about the program we deliver. To me, yes, but that is just one part of the story. So what does true community-led program design look like to you? And what role does cultural humility play in getting it right?
Thank you so much. I'll start with cultural humility because it's one of the words I really like. And it goes beyond, competence. Cultural humility is the practice of listening, learning and unlearning, and also co-creating. That is the cultural humility. So I'm Dr. Titi with over years of experience. But if I go into a community that is not mine, even if it's mine, I want to listen to the community. I want to unlearn the perception I have of that community. And I want to co-create with them because they are the ones that understand.
So you will not be going as Dr. Titi.
Exactly. I drop the hat of Dr. Titi when I start to do, cultural and community-led program design. That is how it is done. And I would like to go to where you talk about community-led intervention. Was that what you called it?
Yes, community-led design.
Exactly. And that's where my ABCD comes in. Yeah. So asset-based community development is a community-driven approach that really focuses on identifying, mobilizing existing strengths and resources within a community, rather than focusing solely on their problems. So the way community development is done in most places is that you identify a problem within that community and you send an expert to go fix it, right?
Yeah.
But asset-based community is saying, no, there are existing strengths and resources within that community. And how can you tap it to help them co-create the solution to whatever problem they are facing? And then what does it really do? It focuses on the strengths, not just the needs. Traditional rural health approaches often focus on, the deficit, what the community lacks, doctors, clinics, which is the major problem when you talk about rural health. But ABCD flips it by identifying what the community already has. Trusted community members, traditional rulers, I did a research on traditional rulers. The local knowledge, the women groups, the agricultural cooperatives that are within that community. And then it becomes the foundation of the relevant health solution. When all these things are tapped together, that is where community-led cultural humility, whatever big grammar we call them, that is where it begins to happen. No matter what community, they have assets, they have resources within that community. How can we identify? How can we map? You are the mother of map. You always say mapping. Chinasa, in everything, she wants to map.
Of course, you have to map your stakeholder and your resources to understand what you're going into. I'm a baseline person.
Exactly. An example of that is, instead of importing outside health workers, how can we encourage trainings? In 2 or 3 health workers to come and train women or men within the community as health educators, building on existing structure and leadership within the village. Guess what? In intimate partner violence, you do this work. If you train the women in the community, then people are happy and more comfortable to go to them. If I go, trust me, I'll be there for money tonight. Nobody's going to come to me.
Especially when you make all of this up and you go arrive in your fancy car and they'll be like, they have come again.
But you see me when I go to communities. I don't look this fancy. I look fancy for you today.
But that's how people show up, you know.
Exactly.
You show up like half lost to a community. And, you know, communities also look at you like you're half lost, but if they see their mother heads, you know, coming to talk to them about this and talking to them in a very professional but also respectful way, you know, it opens up that two-way communication and trust. So thank you for this response. And I really like when you train communities, because the truth is that in this time with the kind of development setting we have now, if we don't build community resilience, you know, resources, funders are pulling funding, USAID has gone, you know, some people are, you know, crunching limited resources. But when we can transfer by building together the kind of resources that communities need to build their own resilience, it becomes easy for them to tap into the resources that they don't even know that they have sometimes, or they know that they have, but they don't know how to use it. And then we come and be like, oh, you have this is actually a pathway. This is a pathway for you to get this resolved. And they'll be like, oh, we didn't know right from time. So I usually do like when ABC comes into the conversation.
And something I forgot to mention, I mentioned it at the beginning, is informal networks.
Yes.
In many rural settings, informal social networks like kinship ties, women saving groups, or even local religious leaders already exist. And how can ABCD help identify and activate these networks to promote health campaigns, delivery care, and even provide psychosocial support? So, for example, existing village association can help us spread mental health awareness or train peer counselors rather than launching an entirely different initiative.
Thank you. So I want to pivot a little bit now. We've discussed all of these things, we've crunched them, and we have to synthesize them. For policymakers or program designers that are tuning into this series, how can they better integrate mental health in all of these that we've discussed? Gender protection, gender equity, a general protection of different vulnerable groups, you know, into rural health strategies in ways that actually, you know, is culturally and practically grounded in ways that people can receive respectful care.
Yeah, thank you so much for that question. So when you talk about policy, I like policy because it deals with numbers.
Yes.
So without evidence, nobody is going to listen to you or implement your policy. So I really want a situation whereby policy makers or people that really design policies are going into the rurals to take the data that they need. Without actually getting those data, there's no how you can make recommendations for the gaps that are within those policies. One of the I don't know if I've mentioned it to you, but one of the reasons I decided to do a master's in public policy was because I felt with the work we're doing in the grassroots community in Nigeria, we were still lacking the numbers. So I wanted to empower myself in a way whereby I can know how to get the numbers from where the problems are actually happening. So policy has to go beyond where data is readily available to where the data is not. You remember I did a pilot study in Nigeria. I could not go on because it was hard to get the data. Until we go there ourselves and collect the data or have money to collect the data. So one of the things policy has to do is allocate some funds for people to really get to the root of where the problems are. So that when this data is collected, then policies can actually be made to support the rural communities. If not, that gap will continue to exist.
Thank you so much. We will take a little break and come back. Do you want to help drive rural health forward? We are looking for passionate volunteers to support our work, from research to storytelling to outreach. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up. Welcome back. So, Dr. Titi, I will try as much as possible to reflect all that you have said, and there are a lot. One thing that I've heard you say is that we cannot build rural health system without centering human dignity. And that comes with understanding the numbers, using them to make informed decisions, using, community-centered approach, but also centering trauma-informed care in the way that these things are designed. That's a powerful reminder to us that addressing rural health means going beyond physical structure. It means listening deeply to the people we are designing the intervention for. And then it also means designing with empathy and recognizing that psychological and social well-being are just as vital as the programs themselves. Care cannot only be accessible if it's not respectful, it does not come with trauma-informed, and it's not rooted in realities of the people that we serve. So, Dr. Titi, in closing, if we are serious about making development program work for women and marginalized groups in rural areas, what is that one shift you believe is absolutely necessary that could change the game if we want to get it right?
This is a very interesting closing, but I'll try my best to center on everything I've said today. The solution to people's problems lies within them. That's what I always say. So for us to shift from that one-size-fits-all way of looking at communities, we have to start to look inward that community. Every community has its own wisdom within it. Every community has its own dignity within it, things that will work for them. And every community has its own agency, especially rural communities who are often less spoken about. When applied to health that we're talking about, it doesn't treat only illness. It strengthens the community fabric as a whole and making it more resilient and better to address future challenges. So the beginning of every solution lies within trying to understand what the problem is, where is the problem coming from, and that lies within the people in that community. Thank you so much.
Well, listeners, you've heard it all. I have nothing to add in addition to this closing response. So, Dr. Titi, thank you so much for being here and for pouring your heart and expertise and your experience behind the system that we talk about. Conversation like this reminds us why rural health is not only about healthcare access. It's not only about going to the hospital. It's not only about going when you are at the point of needing care. It comes from a whole, health and well-being of humans. And we can only do that if it follows justice, it comes with dignity, and it provides healing. To everyone listening, thank you for joining us on What About Rural Health. If today's episode moved you, challenged you, or made you think differently, please follow, subscribe, and leave a review on your favorite podcast platform. And as always, let's keep asking the question, what about rural health? Until next time, I am still your host, Chinasa Imo. Bye.